Hello. Welcome to Differentiating Dementia, Delirium, and Depression in Geriatric Patients. We are participants in the Dakota Geriatric SQUEP grant. We would like you to be able to use the materials to help differentiate between delirium, dementia, and depression. We hope by the end you can list some differences between delirium, depression, and dementia, and most importantly, we hope you will be able to plan some interventions based on your ability to differentiate between delirium, dementia, and depression. For this activity, we would like to introduce a case that will help you focus on differentiating between delirium, dementia, and depression, noting that often there is some overlap in terms of these diagnoses. We have an 83-year-old female who presents by ambulance who has not been eating today and did not want to take her medications at assisted living this morning and then fell. She has no grossly apparent injury but is not herself. She has a history of cognitive impairment and usually is cooperative and eats meals and participates in all activities, but today has not wanted to come out to eat and wants to stay in bed. She did eventually get up and was incontinent of urine, and while trying to change fell. She could not get herself up, and the staff decided to call the ambulance to send her to the ER for evaluation. Her vital signs show a pulse of 102, respirations 18, blood pressure 95/72, temperature 99.2 degrees Fahrenheit, and O2 sat was 99% on room air. Besides mild tachycardia, her respiratory and cardiovascular exams are unremarkable, and she has chronic 1+ pedal edema. She is incontinent of urine and does cry occasionally. She is oriented ×1. The information today was initially generated using ChatGPT and is meant to help differentiate between dementia, delirium, and depression. If the diagnosis is missed, it can lead to poor outcomes and unnecessary suffering, so recognizing the differences will help us optimize care. To differentiate between these three, we will look at onset, course, mood, attention, and reversibility as clues to what we might be dealing with. Dementia is usually gradual in terms of onset over months to years, and there is a progressive decline in function. The mood can be variable, and attention is usually intact early, but is not reversible. Delirium is usually sudden in onset, a significant change over baseline, usually over hours to days. The course is usually fluctuating or acute, and the mood also can fluctuate. Attention is impaired, and it is usually caused by something else going on medically, so if the source is found and treated, the condition is reversible. Depression does not usually occur suddenly. It usually comes on over weeks to months. It is usually chronic or episodically worse. Mood is low and may be apathetic. Their attention is usually intact, and it is with treatment reversible. Dementia is a progressive neurodegenerative disorder that has a number of subtypes. Signs of dementia include memory loss. Typically short-term is worse than long-term memory. There is disorientation and poor judgment. Tests that are helpful to screen for dementia and to help with diagnosis are the mini-COG, as well as the Mini Mental Status Exam, MMSE, the Montreal Cognitive Assessment, MoCA, and the St. Louis University Mental Status Examination, SLUMS. Current management relies on cholinesterase inhibitors and routine supportive care. Delirium often does present with an acute fluctuation in the attention and cognition. Common triggers do include urinary tract infection, pneumonia, medications, or other infections. This often presents in those hospitalized for an illness or in those who have underwent surgery. A tool for assessment for possible delirium is the CAM or confusion assessment method, which we will talk about in a different microlecture. Management relies on making a diagnosis of the underlying reason and treating that appropriately, managing electrolyte abnormalities that may be contributory, improving hydration, and using reorientation strategies and protecting them from falls or other untoward effects that can happen when patients are confused and/or agitated. Avoiding medications that may cause more sedation and lead to poorer outcomes. Depression is an affective disorder that can have cognitive impacts. The symptoms of anhedonia, low mood, and poor sleep and appetite can make it hard to differentiate from dementia, and when it mimics dementia, it can be called pseudodementia. The PHQ-9 can be a tool for assessing the patient's mood, and in our elderly patients, the Geriatric Depression Scale, GDS, may be helpful in looking at depression in an older patient. Management usually involves an antidepressant. In our elderly population, some of the SSRIs may be a good choice, and psychotherapy and cognitive behavioral therapy may be helpful. Here we have an 83-year-old female with cognitive impairment who has fallen. Let's review her history. Her current medications include lisinopril HCTZ 20 over 12.5 milligrams by mouth daily, amlodipine 10 milligrams by mouth daily, celecoxib 200 milligrams by mouth daily, Aricept 10 milligrams by mouth daily at bedtime, citalopram 20 milligrams by mouth daily, and simvastatin 40 milligrams by mouth daily. She has not taken her medications for 24 hours. She scores a 4 on her Geriatric Depression Scale. She scored a 17/30 on the MoCA. Her exam showed her to be mildly tachycardic with a pulse of 102, and her BP was 95 over 76, R18, O2 sats 99% on RA. HEENT unremarkable. Lungs CTA, no wheezing rales or raunchy, heart, regular rate and rhythm, tachycardic, normal S1, S2 no murmurs, abdomen, soft bowel sounds slight, non-distended, no palpable masses or tenderness. Extremities show 1+ pedal edema. Labs show a WBC of 12,200 and HGB of 13.2, platelet count 450,000, sodium 136, potassium 3.3, BUN 30, creatinine 1.8, lactic acid 2.5. UA shows 1030, specific gravity, cloudy, glucose trace, protein trace, leukocyte esterase 2+, 20 to 50 WBC per high power field, 5 to 10 RBCs per high power field. Blood cultures are pending. So what do you think? The confusion assessment method was positive with positive responses to 1 and 2A and the presence of 3 and 4. This looks like delirium, since she had a sudden change in her mental status, and although she does have an underlying cognitive impairment, she has an underlying urinary tract infection likely and could be septic. Admitting her, IV antibiotics, and monitoring closely, she is likely to improve. The change in environment will likely lead to more confusion, and we will need to watch for risk for falls and manage any short-term confusion with non-pharmacologic interventions. In summary, dementia, depression, and delirium can be hard to differentiate, but the setting and the context do help. Depression can look like dementia, so be open to it being a possibility. If there is an acute change, delirium is more likely, and search for an underlying cause and treat. Dementia oftentimes early on is thought to be possible normal aging, and take time to talk to family and patient to help you appreciate the whole picture. Here are some references for you. Thanks for your time today.